highlight the publication of this data set, which represents the first time we've publicly reported all the data from people in treatment over the last year. The purpose is really to try and highlight the richness of the data, and also to stimulate thinking about it and how it can be used further, in fact, to both improve services and to understand the outcomes for individuals who have gambling problems. If I may go through a few practical issues first. We've muted everyone's microphones because so there's less distraction for the presenters and other contributors. The session is going to be recorded, so if anybody doesn't want to be recorded, they should switch their cameras off. And we're going to use the chat function to have questions. And what we ask you to do is select GambleAware as a recipient for the message. And then we'll pick up the messages and we'll tell the whole group what the question is and direct it to particular presenters when we get there. We have a variety of presenters this morning. We've got Andrew Jones, who's the Director of ViewItUK, and he's a Senior Lecturer in Healthcare Sciences at the University of Manchester. We then have Anna Hemmings, who's CEO of GamCare. We've got Fiona Palmer, who's CEO of GamSTOP, the UK's National Online Gambling Self-exclusion scheme, which has been running since April 2018. And finally, we've got Amy Sweet, who's Research Manager at GambleAware, and she's managed the treatment needs and gap analysis research, which was published in May 2020, and has a very good overview of this data, which she will be sharing with us. I'd like to start by making a couple of points about the data. Firstly, I think it's important to recognise how far we've come in being able to publish it at all. It's a very complete data set. It's good quality data reporting, and it provides a rich picture of what's going on in gambling treatment. And we've been able to report on over 9,000 service users who've had treatment. What's also very good news about this data is that we've shown that 90% of them had a reduction on their PGSI score, and a slightly smaller number showed reductions in their core 10 score. So we know that the treatment that's being provided across the system is both reducing gambling and also people's psychological distress. We also know, and it's documenting well, that there's a significant change over time in the gambling problem, the sort of gambling people are engaging in, and the sort of problems they're developing. And we've been able to demonstrate that. And it's probably not surprising, but it helps us target properly the sort of treatment, and it helps us understand how to reach people. I also think it highlights in some ways how much work we have to do in treating people with gambling problems. It's great that we're reaching 9,000 people, but we also know that 9,000 people is probably a very small number compared with the number of people who are estimated to have problems with gambling in the country. And we only have to look at the drug treatment data to know that in that area there's a much higher level of penetration in the treatment population. I also noted that we have shown that we've reported on the number of women and the number of people in ethnic minority groups who are accessing treatment, and those numbers are perhaps disturbingly small as proportions of people accessing treatment. And I think that gives us a very good idea about how we need perhaps to target treatment to particular groups, and we need to think of increasingly creative ways of making sure we engage people in treatment. However, what we've got now is a good baseline. We've got a good understanding, and we're very grateful to our speakers who are going to give us their thoughts about both how this data has been produced, and also some thoughts about how we will look at further data and look at this data more in the future. So if I can hand over to our first presenter, who is Andrew, who is going to talk to us in more detail about the data. So Andrew, thank you.
Thank you, Emily. Yeah, so just to introduce myself, as Emily said, I am a senior lecturer at the University of Manchester. My background is effectively in addiction research, and I've worked for most of my career with the National Drug Treatment Monitoring System data in various guises. And I will now share my screen. And as Emily said, I'll just talk a little bit about the background and how the data has come together and how we've come to this particular position. And of course, it's not clicking forwards. There it is, excellent. Okay, so I just want to explain first of all, because you may have seen in a press release or from what Emily said, that GambleAware commissioned ViewItUK to construct this data. So I just wanted to give a little bit of background on that. So the university, as most universities do, promote startup companies to be produced sort of from within the university. The reason for this is because it tends to be on projects that work in a slightly different space to normal academic work. So often they are they're either product-led or service-led, and rather than focusing on the sort of standard academic model of applying for research council funding. So these companies tend to operate outside of the university premises and importantly don't incur academic overheads. So this particular company, ViewItUK, myself and colleagues formed this out from within the National Drug Evidence Centre, which has been engaged in monitoring substance misuse treatment for over 30 years. So I'm sure a lot of people listening are very familiar with NDTMS. I'm not sure how many people are familiar with its predecessor, the DMD. That was the Drug Misuse Database. You're showing your age if you're nodding right now, but yeah, so this was implemented in 1989 and 1990 across the country. So we were always responsible for this information in the northwest of England. But latterly, we started to work with not the precursor to PHE, but the people who were in charge of this system, which is the National Treatment Agency, to help them to implement a national reporting system. And we carry on this work through to this day with Public Health England. So the data reporting framework, DRF, has been in existence long before I got engaged with the project. Data has been collected since 2015. There was a specification of the data that went out at that time for everybody to conform to. And largely agencies do in terms of the data fields that are collected and the contents of those fields. But there always has been a certain level of non-conformity across agencies. In some ways it's in a minor sense because it's around the structure of the sort of data tables and the naming conventions, which don't seem that important until you try to actually combine the data nationally, because they don't all sort of map onto each other as it stands. So we were brought in to form a national data set, which has effectively been a project in accommodating these current differences between agencies. So we have data import routines that convert everything to the same format, so it can all be merged into a single national data set ready for analysis. We are, with the agencies and GambleAware, working towards harmonisation of this data. So we'll soon be providing an updated national data spec and a single point of entry, so that everybody can conform exactly to the same format for data. So again, this will be similar to what happens with NDTMS. So you can produce the data through any system as long as it conforms to a set format. And of course, once we have this national data set put together, that then enables the national reporting, which today is all about. And wider than that, of course, we can also chunk up that data, for example, to look at sort of regional data, and already we've supplied data in some format to 4 regional public health teams. So it's already in active use. So the DRF itself tends to be made up of 4 separate files. So there's a client file, which effectively contains demographics and client status details. What is called the history file, which actually is details around gambling. So it's where does gambling happen? What sort of activities are people engaged in? And what effect has that gambling had? on them. We collect a referral file, which is effectively throughput figures and details, such as referral source, start and end dates, and discharge reason. So that enables us to sort of to put any individual cases or episodes within a particular date period and work out, for example, waiting times, length of treatment, etc., etc. And an appointments file where information is collected for every single appointment that a client attends, which enables the monitoring of progress throughout treatment through scores such as PGSI and Core 10. And of course, we can then combine all of these tables together to look at different characteristics and treatment by different criteria. So an example of that might be, one of the things we've done for this report is look at the earliest PGSI score within treatment and the latest PGSI score within treatment, so we can start to map progress over the entire course of treatment. And by mapping to other tables, we can then look at that by client characteristics or by gambling type or by discharge status. So there's a fair amount of quality control involved in this project, the most obvious one of which is to monitor the level of missing data. I was really pleased to see when I got hold of this data for the first time that the level of data completion is very impressive throughout the entire data set, which is a real bonus because it often takes many years to get up to those kind of standards. Even so, I still need to apply various validation techniques. So, of course, data are validated at the agency level, but by collecting the national data set, I can then apply an extra layer of validation, because sometimes it's only when you actually analyze the data and sense check the results that feeds back into any issues that data might have. So it enables me to check for the correct use of codes, that the correct ranges are used within each field, to keep an eye out for defaults and system created values. So as can sometimes happen, what may seem like a valid entry in a field could actually be, for example, a 0, which the system has been set to default to, which can actually skew the data. But by looking at the results, I can actually check for those. And ghost cases, which is really important. Again, I think anybody familiar with NDTMS knows that if you could say that it's got an Achilles heel, it would probably be in the fact that although start and end dates are really useful for placing a person and a treatment in a period of time, of course, if you don't complete the discharge date, then the case stays open forever. But through different data definitions and data management, I can actually keep an eye out for those kind of things. I'll talk more about case definition in the next slide, but I can actually look for cases which may seem to be not quite right and feed those back to agencies so we can get a feedback loop going and constantly improve the data that's being provided. So in terms of case definition, what qualifies an individual and a treatment to be included in this report? Well, first of all, and most obviously, only agencies that supply DRF are included. Don't know about any others. Individuals are defined by each particular service. They receive a unique client code. And then if an individual has multiple episodes of treatment, then those individual episodes, again, receive their own code. So that enables me to map individuals and characteristics to actual episodes of care. So any episodes of care which are overlapping the treatment period are included. So these are not necessarily contained completely within. They could start before the start of the period but finish within the period, and they could start within the period but finish outside the period. But any treatment which is overlapping is included. In order to qualify, what I do is to make sure. So what we're looking for here is people who are actually treated by the services. So you may have individuals who are referred but never actually turn up. So we have data on those, but they would not be included. We also have individuals who receive an initial assessment, but it's decided that the client or the treatment are not appropriate for each other. So again, treatment is not started. So to qualify for this report, you need to have at least one treatment appointment recorded. And I also do checks, I mentioned ghost cases before, to see when those appointments have been held, so we can actually try to identify any cases that look sort of falsely open and exclude those. So we try to narrow it down to those that we know received treatment within this particular period. It includes structured treatment only. There will be lower level contact with individuals which are not recorded into the system. So it's really important to note that this report is not meant to be a measure of all activity around gambling services across the country. It's only those that conform to this definition of treatment within this period. And the cases currently include both gamblers and others, which is split into affected others, those affected by gambling, perhaps, and others gambling, and those at risk of becoming a problem gambler. So last slide, contents and features of the annual report. So there's a breakdown of the vast majority of all the data fields that are collected within this report. The report's split into sections, which hopefully make sense, around client characteristics, gambling profiles, service access and engagement, treatment outcomes, and trends. If you were to say there's any emphasis on any of those, I would say in terms of sort of length and depth, there's probably a slightly greater emphasis on gambling details and sort of progress, so discharge reasons and progress within treatment. Mentioned before that there's both gambling clients and others. So where available within the report, we always break everything down by gamblers plus others. Some information is only available for gamblers, so it's only presented for them. Elsewhere, we break these down, and that's important because they are actually quite a different set of clients, certainly demographically, because the affected others tend to be older and far more likely to be female. So this report, as I said, it's a sort of a descriptive view, overview of the vast majority of fields which are collected. So in that sense, it's designed to be repeatable and comparable across years. So it's not a themed investigation each time. It's something which will be repeated largely in a similar fashion to be comparable across years. And we already have enough data to present 5-year trends. There are, of course, multiple ways that you can look at this data, which are not necessarily included within the annual report. But again, I think one of the ideas is to sort of stimulate thought and questions, and we can then potentially look at answering those questions outside of the annual report format. And again, just to refer back to some systems like the NDTMS, this is something which goes on all the time. So we have media requests, government requests, public requests, normally through Freedom of Information Act, and the list goes on, and we can answer those on an ad hoc basis with the data throughout the rest of the year. There is flexibility to add and amend within these consistent case definitions. So we are currently adding some fields to future DRF, so they will then be included in the annual report. And finally, just to say that a new DRF is on the way, as I've just mentioned. There's going to be additional fields collected, so exactly the same core data set that has gone into this current report, but that will then be appended by additional fields and data collected, which will be reported on it in future years. And I shall stop there.
Okay, thank you very much, Andrew. We've had one question in that actually is so relevant to this data that I think I might ask it now. Someone called Martin Jones asked, how many of the 9,008 received treatment previously? Do we know that from this data?
So Martin, you're testing my memory of every single figure within there, and so don't quote me on this, but it is actually contained within the report. I think it's effectively roughly a quarter of individuals have previously received treatment. And that tends to, the definition that tends to mean treated at that particular service. Okay.
That's also another question from Martin, which I'm not sure we can answer all of it. Are NHS numbers in the DRS system? I think I know the answer to that, but I'll let you ask that.
So the answer is no. At the moment, Martin, as I said, it's individuals have a unique code at service level. so we can sort of define uniqueness in a sense at that level. We are working towards collecting an identifier which is comparable across all services. So it won't be NHS number, but we'll formulate some kind of identifier so that we can then actually cross-reference across services.
Okay. Another question, what is the average PGSI at referral? I think that's in the data, isn't it?
That is in the report, and
Yeah.
I am not going to risk guessing it in case I get it.
Is there a list of DRF agencies in the report? I think.
Yes, I would like to see John nod at this point because I think he wrote the introduction. But yes,
Yeah,
yes, there are. So it's in the introductory material. Right, there's no breakdowns within the data by individual services, but there's a description at the start to explain who contributes.
And another question: have the number of people who presented but don't engage, is that reported?
No, so I think that refers to what I said about people who are referred but don't engage.
Yeah.
No, that number's not actually reported. As I said, it could be calculated within the data, but it's not presented within this report.
And we'll have the last two questions. How do local authorities request data from the DRF?
So currently I have received requests via GambleAware.
Yeah.
I mean, I don't know if John, if you want to come in at this point to add to that, but.
No, yes, it's helpful to get requests direct to GambleAware if local authorities wish to use this for service planning. But Amy, who's speaking at the end of the webinar, will have more to say about the use that local authorities can make of data and how they can use it.
And a couple of final points. Do we have any 2019-20 figures, specifically those who sought treatment from the BAME community only? And I know that's quoted in the data in the report.
So there is an ethnicity breakdown within the data. So yes, yeah. Okay.
And level of missing data. Again, I think that's quoted and that's actually in the report. I'm sure.
Yeah. So there's in fact, the very first table of the report gives the percentage of completeness for each field.
Oh, that's what I understood. Right. I think we'd better move on. Can we move on to Anna, who is CEO of GamCare, who's going to give GamCare's perspective on this?
Okay, so I've just shared the screen. Hopefully everyone can see that. GambleAware have asked me to present both some of the National Gambling Helpline data and the DRF data. The reason for that is that a number of services operate together as the National Gambling Treatment Service, and that's made up of the National Gambling Helpline, which is operated by GamCare, and then treatment services delivered directly by GamCare, as well as by the 13 agencies that make up our partner network, the specialist NHS services, and Gordon Moody's residential services. So the main focus for today is the DRF data, but we've just got some helpline data at the start to add some context for you. So I'll go through that quite quickly, if the slides move. Hold on. Okay, slight technical issue. Just stop the screen share and do it in a different way, I think. Okay, so on the National Gambling Helpline, in 1920, we saw a significant increase in what we call target calls. So that's calls from a gambler or affected other people who are seeking support around their gambling. So that meant that we took 38,800 calls across the year. Actually, that's driven by an increase in repeat callers and also the new callers. which is quite interesting. So we're engaging with people repeatedly sometimes, either because they're calling us as an inbound call more regularly, or because we're also making significantly more outbound calls as well, either because people want some follow-up or for us to check on them in other ways and touch base. So of callers to the helpline, 65% were male, but actually similarly to the treatment data, if we look at gamblers specifically, 80% of them were male. We see more women in the affected others group who are calling the line. Generally, the age range is fairly young. So 6 in 10 callers are aged under 35, and the majority of callers are employed. In terms of how people are gambling, 75% online and 46% offline. Some obviously do both, but similarly to what we'll see in the DRF data, there has been a trend towards online over the last 5 years or so. In terms of impacts of gambling, the 3 key ones that we see are on family and relationships, mental health and well-being, and debt. So this slide just looks at family and relationships. About just over 2/3 of callers to the helpline are in a relationship, either married or with a partner. And 45% of callers talk about family relationships being impacted by their gambling. In terms of debt, about 70% of callers are talking about financial difficulties and debt caused by their gambling. And again, this pulls through, and we see very similar things in the treatment data. And then finally, in terms of mental health impacts, anxiety and stress are the most commonly reported, and that's reported in 62% of gamblers and 53% of affected others. And as we're aware that gambling can have significant impacts on people's mental health, and we do see that 11% of people contacting the helpline are self-reporting suicidal thoughts or feelings, either currently or in the past. So that's not necessarily 11% of callers are actively suicidal at the point of the call. That number is much lower, and of course we take appropriate actions where that is the case. So that's just a very brief oversight of the activity on the helpline. If we move on to look at the DRF data, which covers the services within the National Gambling Treatment Service, if we look at trends, first of all, in terms of numbers treated, you can see that over the last 5 years, we've seen a good upward trajectory in the numbers coming forward, a slight decrease in 2018-19, which I think corresponds to when some of the services were recommissioned. So although this is positive, I'd highlight the point that Emily made at the start, that we're heading in the right direction, but it's not a large proportion of the estimated number of people with gambling issues at all. So there is still more work to be done. So moving on to look at age and gender. So this is very interesting. In terms of the treatment population, 75% overall are men, but there's a very different pattern, as you can see, for men and women accessing treatment. Overall, we're looking at people who are fairly young, the majority under 35, particularly for men though. We are seeing younger male gamblers, and a lot of them are gambling online. Women are more represented, I suppose, in the affected other group, and that might be leading to some of this different distribution of women in treatment, which is quite interesting. But another thing that I think is very much worth further exploration is whether women are gambling in different ways at different ages. So it's difficult with this data to say whether the distribution of women is linked to the fact that they're more affected others, or the fact that they gamble with different products and patterns than men. So very interesting things to note there, I think. In terms of people coming forward, so the vast majority really are gamblers, but I think it's interesting that we're seeing a significant increase alongside that in affected others seeking treatment. So the number of gamblers has gone up from 5,288 to 7,473. and the number of affected others has doubled in the same period from 563 to 1,192. And that's something we're pleased to see. We do encourage affected others to seek treatment, partly because the impacts of somebody else's gambling can have, significant detrimental impacts on those around them, but also because affected others can be instrumental in helping gamblers to get the support that they need. So over time, we're just seeing a gradual shift in the distribution of gamblers versus affected others in treatment. Of course, we want both of those to continue to rise going forward. Okay, so a lot of data on this slide, so I'll just pick out some of the main trends in terms of how people are gambling. And the main thing, I'm sure you're all aware, is this trend we're seeing towards online. And that's gone up from 56 or 57% 5 years ago to nearly 70% now. And no doubt that reflects changes in our lives more widely, but also reflects the availability of online gambling products. The other significant change, of course, is that gambling in bookmakers has reduced. So that's gone down over the last 5 years. Although, of course, lots of people, people with the most severe gambling problems will often have numerous accounts and numerous ways of gambling. So there's overlap in these populations. The other thing I would say is that that Black and Asian groups that we see in treatment are much more likely to gamble offline than online. So we need to be thinking about how we can segment the population to ensure that we improve access for those that are currently underrepresented. Oops. So in terms of completing treatment, we have seen over the last 5 years an improvement in the number of people completing their treatment successfully. So that's very positive. Obviously, we do get some people who drop out and a smaller number who are referred on within the system. So we're positive about that, but nonetheless, of course, we still are working to improve our outcomes all the time. This is just looking at trends in gender, which I think we've touched on before, but this is looking at the overall population in treatment. So we are seeing some change here. We are seeing, I mean, in the last 5 years, the number of women engaged has doubled, which is positive. But they, as I said earlier, they are overrepresented as affected others. And female gamblers, which is something that we've done lots of work around at GamCare, do often talk about feeling stigmatized and feeling that it's perceived as a male problem, so finding it sometimes harder to come forward for treatment. So I think that's something that we really need to continue to work on and explore, is firstly how women access treatment and how they come forward, but also how they gamble. Is that we haven't really got enough information about how women are gambling, when they're gambling, and what drives their gambling. But the feedback we get from female service users suggests that it's slightly different to some of the patterns we see in men. In terms of ethnicity, this is an area where you'll see fairly limited change, unfortunately, over the last 5 years. We do engage mainly white and white British groups. Black and Black British and Asian British groups do gamble more offline, as I said earlier. And we need to do more work, I think, to engage those communities in treatment. In terms of employment status, again, this has remained relatively stable over the last 5 years. So the majority of gamblers, around 75%, do tend to be employed. And although the proportion that's unemployed is fairly low, one thing I think that's important to note is that that group are considerably more likely to drop out of treatment and lose contact with treatment services. So we do need to be thinking about how we target those groups and try and keep them engaged as far as possible, because it is also possible that people who are unemployed are disproportionately affected by gambling because of poverty, for example. So on this slide, we are looking at PGSI score between the first and last appointment. And we do see significant improvements in this, although of course there is also a group that don't progress as well in treatment. That may be in part because there's the smaller proportion that drop out of treatment. But fortunately for most, they make a good improvement. And I think this is fairly, it's comparable to improvements we see in our app services and probably slightly better than the outcomes you see in drug treatment. But nonetheless, we've got some work to do, I think, to ensure that people do progress well. The other issue we have with PGSI is that it's a population level screening tool. That's what it's validated for. And it consists of 9 questions that are asked retrospectively over the last 12 months. It's not validated as an outcome measure. So although all of the services use it to monitor how people are doing in treatment, the reason we do that is that it's the best validated tool there is internationally as it stands. But we do need to develop better outcome monitoring tools, or indeed look at whether the PGSI could be validated for that. So it's a bit of a combination of being unsure if we're using the most effective measures here, but also continuously trying to improve the treatment interventions we offer. And then finally, we've got the Core 10 score. So I'm sure most of you know Core 10 is a quality of life measure. Again, here we do see significant improvements in people's quality of life between the first and last appointment. So there's lots of positive direction of travel. As Emily said, this is the first time we've had this data set published and available as one, and it sets us in a good direction, I think, to be exploring more research around it and further improvements in both the engagement of people in service and the outcomes they can achieve.
Okay, thank you very much, Anna. I think we will go straight on to Fiona Palmer at this point, and then we will go back to questions at the end, so we don't run out of time. So can I hand over to Fiona, please, if she's here? Good.
Thank you, Emily. Sorry, yes, I am here. Good morning, everybody. We thought that it'd be a great opportunity to share some information that we see and the trends and the data that we see at GamStop. We've noticed during lockdown, we've had a number of meetings, and actually there's some very similar trends and patterns of behaviour that we've seen to those presented by Anna for consumers who are contacting the National Gambling Helpline. But before I progress onto that, I thought it'd be helpful just to give a very quick overview as to what GamStop is and what we do and the service that we provide. I'm not going to read everything, so I've purposely written the slides so you can read yourselves. However, I thought it's worth pointing out that we are a free national online self-exclusion scheme, and we have all online gambling operators who are licensed by the Gambling Commission integrated with our service. What this means is that any individual who comes to GamStop, to our website, and registers with us, they will be self-excluded and blocked from being able to gamble on British gambling licensed operators. The way that we're funded is that gambling operators pay an annual license fee to access and integrate with the GamStop service, and this covers the cost of operation. With us being a not-for-profit organisation, this ensures that the services remains free for consumers to use. To date, we have in excess of 166,000 people registered with the scheme. How it works is that a consumer comes to our website, they register their details with us. We have to verify their details to make sure that the data that is entered belongs to the individual entering it. This is because they then select a minimum duration for which to be excluded. And during this time, we will not remove the exclusion. It's a tool to enable consumers to obtain some breathing space and go and seek treatment and support for their gambling. We maintain a register of consumers, so people who have an active self-exclusion with us. We also maintain information about people who have had an active self-exclusion with us, but have subsequently, once their minimum self-exclusion period has expired and they have elected to be removed from our service, we maintain the information that they were previously self-excluded. All operators are required to integrate with us, and they have to undertake a real-time reactive check of any individual, any customer who attempts to register with them, and also any time an individual attempts to log into an existing account. And we return a real-time response advising the operator as to whether or not that customer has an active self-exclusion on GamStop, or was previously active on GamStop, or we have no record of that individual. In addition to the real-time check at registration login, we also require all operators to undertake a check of their entire UK customer database at least once every 24 hours. This ensures that we offer the maximum protection for consumers. It also enables operators to remove any GamStop registered users from their marketing databases. Just looking at the data from when we started, our service went live to consumers in April 2018 and has been rapidly growing ever since then. Upon registration, individuals are offered the choice of applying a minimum self-exclusion duration of either 6 months, 1 year, or 5 years. As we can see, that the most popular duration selected is 5 years, with 67% of registrations well, in the period of April 2018 to March 2020, having selected this. Once the minimum duration has expired, I must stress that it still remains active for up to a further 7 years. However, in this additional 7-year period, an individual can contact us and go through a reinstatement process. If they contact us before their minimum selected duration has elapsed, we will not remove their exclusion. Moving on, focusing on to the period in question. So April 2019 to March 2020. Looking at the age profile of users, we can see that it's very similar to the age profile that Anna was talking about. Similarly too, we've observed that male users of the service are generally younger on average than females. And we also have, on average, 30% of our registered users are females. This age profile has been consistent since the commencement of the service, so we are not seeing any major fluctuation in the change of ages upon people when they register with GamStop. Between April 2019 and March 2020, we've had 66,000 people register with us. On average, this is around 5,500 new registrations, so new people coming to our website and registering with us. And as we can see, there isn't much variability in the monthly registrations. And for the first 2 years of operation, this has been pretty consistent. In addition to new people coming to our site to register with us, we also provide the functionality, and new functionality was released in August 2019 to enable existing registered users of our service to apply additional or extensions to their registrations, their minimum active period with us. And we can see from here that in August 2019, when our new functionality was put live, this is a self-service on-site account functionality where an individual can actually go in and manage their self-exclusion, so they can extend their exclusion and they can add additional information to their registration with GamStop. We can see that this was this functionality has been well received, with the average number of existing users adding new exclusion periods. This volume has nearly tripled since, so we're going to 900 per month on average new exclusions being added versus 300 prior to the functionality being in existence. Another area that we monitor is contacts. We have a contact center. And so it's contacts to our contact center. There are two main trends that we monitor. One is for people contacting us after their minimum self-exclusion period has expired, requesting to remove their self-exclusion and subsequently removing the self-exclusion. And we've noticed that we have a steady trend. So of people who are wanting to remove their self-exclusion. So on average, it's around 500 per month. But the more interesting one that we do also monitor very closely is those people, contacts from people who want to cancel their exclusion. So this is before the minimum self-exclusion period has elapsed. These people, we do not remove the exclusion. As I said earlier, the exclusion is a minimum period selected by the individual when they register with us, and they have elected to be excluded, and they've asked for assistance from ourselves to be excluded from being able to gamble for that minimum period of time. So if we receive a request for someone to cancel the exclusion early, we will not action that request and the exclusion will remain active. However, we do have a warm transfer functionality and facility available whereby our contact centre advisors can transfer calls over to the National Gambling Helpline. We also signpost treatment and support services available to our consumers, both via our website and also via contacts to our contact centre. I thought it would be useful just to take a look at since March 2020. So just an effect of COVID-19. So COVID-19 hit, and particularly with us being online gambling, with other gambling services being closed, I thought it'd be helpful for you to see the trend of our registrations, and also, as I say, the contacts from people requesting to cancel their exclusion early. As we can see here, that the number of new people registering with GamStop has declined. This, though, having 166,000 people registered with us, this is in line with expectation that we would expect new users of our service to decline. However, encouragingly, we do see that existing users of the service are applying additional self-exclusions, minimum self-exclusion periods, with the on-site functionality. The number of, it's the pale brown line here is the most interesting one, with the volume of requests to cancel an exclusion early. It remains at a higher level since March 2020, averaging over 1,000 requests per month received for this. As I say, these are the prime candidates for us to look at transferring, using our warm transfer functionality to transfer these individuals over to the support and treatment that they require. I'm going to stop there because I'm conscious of time. However, I hope this has been useful for you.
Yes, thank you very much, Fiona. We've now got, I think, not sort of 5 minutes for questions. I'll start off with, there's a question specifically about GamStop, and then we'll go backwards to ask previous ones. Why can't GamStop offer lifetime self-exclusion?
We are continually looking at and reviewing what we're doing with this self-exclusion. When we set out, we are conscious that self-exclusion that we offer is about, it's excluding the data that is entered with GamStop, and therefore we could not guarantee exclusion of the individual. We are excluding the data provided by the individual. It is one area that we are reviewing and keeping under monitoring as to whether there's a feasibility around it, but we need to make sure that we're extremely clear to users of the service what lifetime would mean and be. It would be of the data, not necessarily the individual.
Okay. And the other thing is, Joe Evans said, looking at the data, it looks like an increase in exclusions in January, then an increase in requests to remove in March. Is this a pattern produced in previous years?
I think the increase in January, yes, that is, it's a new, we do see quite a significant increase as New Year's resolutions. I think it's that side of things. The March thing we are keeping under review, because this year with COVID, we did see a significant spike and the trends that we saw there. I think the increase in March last year, it will coincide with new functionality that we make available as well. And we've also started to raise more awareness about the service. So again, I think next year will be the interesting one to see and to be able to answer that one more clearly.
Thank you, Fiona.
Thank you.
We've got a question, which is probably for Anna. At treatment end, does non-problem gambler mean abstinent? Anna or John?
Well, it's using the definitions attached to the PGSI, which is a validated screening tool. So if you score below a certain threshold, the PGSI classifies you as non-problem gambler. I would think that would generally mean abstinent in practical terms.
Okay, thank you. An interest in why onward referrals have dropped over the last 5 years from 2% to 1.5%?
I'm not sure that there's a clear answer to that question, but I think, yeah, I couldn't speculate really, but I would estimate that over time that will increase again because we're seeing more services come into the system. We've seen the 3 Northern Gambling Clinics open, the primary care gambling service open, and of course there's the existing services and residential. So I think over time, I would imagine we'd see an increase in referrals within the system. And we just need to ensure that we always capture them on the DRF data.
Okay, and Martin Jones asks, what's the difference between completed treatment and didn't drop out?
Well, so people who successfully complete treatment are completing the number of sessions they agreed to participate in. And then there are a cohort who drop out at some point through treatment that just don't continue to come to their sessions. Yeah, I'm not sure if I fully understand the question.
Can I just jump in? Because I think, yeah, it's similar to NDTMS that you can successfully complete treatment. You can drop out as in simply cease attending, but then there's grey area in between. So people who are known to say to move away or to be referred to a different service prior to completion. So it's not actually a dropout and it's not successful completion. It's something in between.
All right. Okay. So somebody asked about the reported figures for under 20s. Do we know anything about those accessing treatment and what figures are for school children and what treatment's currently available for them? This might be perhaps initially for Andrew and then perhaps for Anna.
Yeah, so if I go first, just in terms of the reporting, so there's no restriction on age applied to the data until we actually do breakdowns of the tables, because there's so few under 20s in the data that we don't attempt to look at differences because they might not be valid.
Okay, and Anna, do you want to say something about treatment for school children or young people?
Well, certainly I know that CNWL and GamCare have both launched services that are supporting young people directly. And I think when young people come forward, they'll be routed to the right service to reflect both their age and their sort of competency and maturity. So, yeah.
Couple of questions about, I think I know the answer to this. What percentage of callers were suicidal currently? Back to the helpline.
It's a very low proportion. I don't have the number in front of me, but we certainly, if people are actively making plans to end their life, we contact emergency services, and we did that on about 30 occasions, I believe, in 2019-20.
Okay, and probably finally, somebody called Hilda Campbell talked about voices of lived experience, mentioning stigma, and talked about that perhaps we should describe someone affected by gambling harms as opposed to somebody being a gambler. And I think that's perhaps an interesting thing to finish on, because I think it's a very good reflection, and maybe it's something we should consider as a sector, because I agree with Hilda, that sort of wording frequently contributes to stigma. So I'm going to go on to the very last presentation, which is from Amy Sweet, who's going to give us a few minutes on treatment needs and gap analysis.
Thank you very much. I'm going to share my screen, so bear with me. Can everybody see that okay? Is that good?
Yep.
Yes.
That is a yes. Fantastic, thank you. So I just wanted to draw your attention to a new webpage that has been published on our website today, which is showing maps that were created using the treatment demands and support data that was collected by YouGov that formed part of the treatment needs and gap analysis research that was presented and published in May 2020. For those that are not familiar with that, you can find all of the published research on our website. So I'm just very quickly going to draw your attention to the new maps published today, hot off the press. So what we've done is we've taken the data from the YouGov survey and we've mapped this to show prevalence across Great Britain. So we've done this by problem gambling severity index, and as Anna will have taken you through what that is, so I won't go through that in detail. And we've got the maps and they're grouped under the PGSI categories. So non-problem gamblers, low risk gamblers 1 to 2, moderate risk gamblers and problem gamblers. And what we can see is the gambling estimated gambling prevalence by local authority. So what we can do is we can zoom in. So example, if we're interested in the Northwest, we can zoom in and we can see by quintile. So that's basically equal groups of 20% of the population grouped to see the lowest prevalence up to the highest. So lowest being the light pink and the highest local authorities in the dark pink. So people are able to just move the map. It's very kind of user friendly. You can zoom in and out and you can look at your specific local authorities. This is kind of very kind of an initial kind of way of doing things. So, you know, there are lots of things that we can look at in the future, but this is kind of the first go at mapping gambling prevalence across Great Britain. The website also includes lots of other really useful tools and resources for organisations working to support people experiencing gambling harms. So we just think that this is a kind of a first go at really trying to understand some of the local differences in terms of gambling prevalence. And it's, as I said, it's up on our website today, so you're able to go on, look at the maps, change the different indicators. And it's also probably worth mentioning, as well as the population indicators, we've also got things like accessibility to gambling outlets. So you can see based on your local area where there's kind of higher density of gambling outlets, but also things like index of multiple deprivation as well. So you can look at your local area and see what your sort of deprivation levels are like in your area. So again, using those two maps is just a way of looking at how you can compare gambling prevalence data to other indicators. So it's just kind of really as a first starting point. So I'm aware that it's now 11 o'clock, so I shall stop talking. But as I said, it's there on our website, so please do go and have a look at it.
I think we've lost our host. I can't see her on the screen anymore. But yes, I think that was everything. And I think, yeah, if anyone has any other questions that weren't asked or weren't answered, please do send them to info@gambleaware.org. So I've just sent that on the chat there. Yes, thank you everyone for coming. I'm not sure. Oh, here we go. Emily's just joined the meeting again. I mean, I think that's it. But yeah, thank you everyone for coming along today.